Okay, thank you. What I'm going to cover in my talk today is I'm going to talk about some things we've already talked about, but I think there's some value in repetition because some of the concepts are confusing and not everyone's on the same level. And sometimes if you hear the same thing twice, you might understand it the second time. And I'm going to talk about, maintenance, and then I'm going to talk about some of the approved new drugs, Darzalex and implicity, that are used to treat myeloma. And then I'm going to touch on Carty cells, which will be the future. But there's so many exciting new things coming that you'll hear about from some of the subsequent speakers as well. So I'm going to define maintenance, and here is what it is. It's basically when we continue to give drugs, even though we cannot see any direct evidence in a given patient that they're working. So normally when we start, like with induction, we give drugs and we see the tumor respond. We can measure markers in your blood, we can do a PET CT scan, we can repeat the bone marrow, we can see that our treatment is doing something. Maintenance is a different sort of situations. We treat you and we can't see that it's actually helping you. And so the reason that we do it is because we've done very large studies where we randomized patients where half the people got a placebo and the other half of people got the maintenance. And we know from those large studies that as a group, overall, the patients that get the maintenance benefit. And every single study has shown that maintenance keeps the disease away longer. There's really no question about that whatsoever. And we think that there's benefit in keeping the disease away. I think you feel better if you don't have the disease. And some studies suggest you may actually live longer as well if we keep the disease away longer. And we call it maintenance because we think we're sort of maintaining the tumor cell where it is. We're keeping it from proliferating. We're keeping it under check. So some patients ask, how do you know if the maintenance, like they ask me, how do I know the maintenance is working? And so I say, well, we could stop it and see if it comes back. Then we'll know if it was working. That doesn't actually give them a lot of comfort, however. And the other thing is, of course, it may be that the disease would come back even if it often does come back even if I don't stop the maintenance. And so we never really know if the maintenance is working or if it was working. But we know from all the studies we've done that in general, for most patients, if you stay on the maintenance, the disease will stay away longer. This morning I showed this slide. Oh no, I didn't show this. Where did I put that slide? No, see, I was in a bit of a rush and I missed it. So I'll talk to you about the slide I showed this morning, see if you were paying attention. I showed a slide of patients who were treated with Revlimid and dexamethasone for 18 months versus Revlimid and dexamethasone until the disease came back. And what I told you was that if you took the Revlimid and dexamethasone continuously, you never stopped it, the disease stayed away much longer. And then what I also showed you, though, was that the overall survival for the people that stopped after 18 months or continued it indefinitely, the overall survival was the same. And so what that means is we recommend that you take maintenance continuously, but if you're having side effects or you can't tolerate it, you should be reassured to know that you will also do well. So it's not like you have to suffer, and have a miserable life to take maintenance. We can find ways to make your life tolerable, and that might include stopping the maintenance at some point. So that's basically my talks. Oh, and so the maintenance has traditionally been with Revlimid because it's such a well-tolerated therapy. I think there's some new studies that are coming, and we've also done maintenance with Velcade, which has been shown to be effective. You heard Dr. Morgan talking about studies that look at the, I think, maintenance with Ninlaro, which is a pill form of Velcade that is well tolerated. And people are, I think, looking at combinations of drugs as maintenance. So that the field is continuously changing I'd say the standard right now for most patients with standard risk would be Revlimid, but if they have high risk features, we might add on Velcade or Ninlaro to that. Now, another class of drug that we haven't talked about very much this morning are monoclonal antibodies. And I think, these, it's kind of, multiple myeloma is a disease of a monoclonal antibody. That M spike in your serum, that's a monoclonal antibody. And so it's only fitting that we should be able to turn that technology around and use it to treat the disease. And these are antibodies that we grow up in the laboratory, and they recognize something on the surface of the myeloma cell, and they attract the immune system to fight the myeloma. The ones that are approved for use don't have any conjugated chemotherapy or anything else. And the two drugs are implicity, or elotuzumab, and Darzalex, or daratumumab. And we tend to think that, that the Darzalex is a little bit more active than the implicity, because we see activity when it's used all by itself, whereas we don't see that with the implicity. But the implicity does have activity, and there's a new study that was just published this year in the New England Journal of Medicine that looked at patients who'd basically failed Revlimid and Velcade, and this was their salvage therapy. And patients were randomized to get pomalidomide and dexamethasone with or without elotuzumab, implicity. And this top curve shows you the progression-free survival. That's basically how long does the disease stay away. And this bottom curve shows you the overall survival. And so you can see, basically, if you look at the midpoint here, that the disease is staying away about 10 months or 6 months, from 4 months to 11 months. This is still published quite early. And that's about similar results that we've seen in other studies when we've looked at the effect of adding in a third agent. So I think this is something that we haven't been using until this trial was published, but I think you might see this being used in the future. Particularly in a lot of patients will have seen Darzalex and they're looking for options. This would be an option with a drug that they haven't seen. And I guess it may be obvious to you or not, but we like to expose patients' tumors to drugs they haven't seen before because they will not have resistance to those drugs. And also, implicity is improved for use with Revlimid. And so we would also consider the use of implicity Revlimid and dexamethasone. But that's where we think the daratumumab is more effective. This curve didn't actually work, so ignore these curves, but the numbers are here. This looks at the daratumumab, and daratumumab they were randomized studies where patients got Velcade and dexamethasone with or without daratumumab, or Revlimid and dexamethasone with and without daratumumab. And both of them showed that the disease stayed away longer if you took the daratumumab. And you can summarize it with something called a hazard ratio. And this hazard ratio here of 0.31, if there was no difference between the drugs, the hazard ratio would be 1. And if it was twice as good, the hazard ratio would be 0.5. So the hazard ratio of 0.3 says it's 3 times as good, essentially. And the median survival was 7 months versus 16.7 months. And this is the result with Revlimid, where you can see the median survival with Revlimid and dexamethasone was about 18 months, and it hasn't been reached in the patients that received the daratumumab. And so they had to look at the 24-month time point. And the hazard ratio, again, was 0.4. So both of these combinations are used to treat myeloma. And daratumumab is a monoclonal antibody, and it targets something else on the surface of the myeloma cell. So the elotuzumab targets something called SLAM-F7. Daratumumab targets something called CD38. And just like BCMA, the names of these things don't really matter. Just know that it's something on the surface of the tumor cell. If we dig into the details of this study, this is that same study, and broken out the patients in whom there was minimal residual disease. And this is just like what Dr. Morgan showed you this morning with another study, that patients who get minimal residual disease just with Revlimid and dexamethasone have the same good outcome as the patients who get minimal residual disease with daratumumab, Revlimid, and dexamethasone. And so that's why we tend to think getting minimal residual disease is our goal of therapy. Of course, what we don't really know is, maybe there's something about these patients who get minimal residual disease with just the two drugs that makes they're just better people, they just have more sensitive disease from the very beginning. And we don't know, maybe these patients, if they had gotten daratumumab, would have, done even better. And we don't actually have that answer. So that's and daratumumab is being looked at in so many different combinations. Perhaps most excitingly, it's being looked at for newly diagnosed patients with multiple myeloma. And in fact, it's approved for use in combination with Velcade, melphalan, and prednisone. But that's not a regimen that we actually use in this country. And so it's being studied now in combination with Velcade, Revlimid, and dexamethasone, which is a standard. And I don't think any of us will be surprised if it becomes the new standard upfront treatment for the treatment of patients with multiple myeloma. And so now I'm going to move and I'm going to talk about CAR T cells, these engineered T cells. And in some ways, it's a similar concept to the monoclonal antibody. We're targeting something on the surface of the myeloma cell, but instead of giving it to you as an infusion of an antibody, we're giving it to you on the surface of your own T cells. And that seems like, or almost seems like science fiction that we can do this. But what we do is we hook you up to a machine and we take out some of your blood, we get your white cells, and then we express this, what we call antigen receptor, or the receptor that's going to recognize the myeloma on your T cells. And your T cells normally multiply exponentially when they're faced with whatever it is that they're supposed to attack. Normally they attack, infections and other things. But in this, by doing this, they recognize the myeloma as being a foreign cell. And so we infuse the T cells and they divide exponentially. And there is both good and bad about that. The good, of course, is that for a disease like multiple myeloma, where there are all these different subclones, having an exponential growth will give you what you need to control it. The bad is that when these cells grow, they're a little bit out of control, and the patients can get sick acutely with what we call cytokine release syndrome from all the inflammation that's going on in their body all of a sudden. And then they can go to the intensive care unit, and they can have neurotoxicity. And so it's investigational, and the phase 1 studies are really just about finished, and the phase 2 studies are opening up. But it's taken a while to figure out what's the best way and the safest way to give CAR T cells. So this looks at 2 of the longest running studies. BB2121 is the CAR T cell from Celgene now. It's called Bluebird. And the LC CAR is one actually from a Chinese company, Legend. And you can see not that many patients treated, right? 43 patients with 39 evaluable and 74 patients with 40 evaluable. And these are all end-stage patients. I think the patients with the Celgene trial would be more like patients in America, whereas the patients in the Chinese trial, they have less availability of drugs in China, and so we tend to think that they're maybe not as advanced as the Americans' patients would be. But you can see 30% of patients, 30 responded, so 70% of patients here and 92% of patients there responded. And that's quite remarkable when you think about, at least in the US, patients that have failed Darzalex and everything to have such a high response rate. And then if you look at the depth of the response, 17 complete responses. So that means when we look in their serum, we can't find any evidence of the multiple myeloma. And 9 very good partial response. That means a 90% reduction. But you'll see the safety. There's any kind of cytokine release syndrome, 63% of patients. But in terms of severe cytokine release syndrome, which we'd call greater than grade 3, it's not that common. But to manage that, the patients would not infrequently have to go to the intensive care unit, and they'd have to get drugs, one called Toxi, to deal with that. And so we tend to think of it as similar therapy to stem cell transplant. We don't think of this as like easy therapy that everybody is necessarily going to get. And until we learn the best way and the safest way to give these things, we're still learning that. But this shows you how long these disease can stay away. What you can see here is that 12 months, so median of about a year in progression-free survival with this therapy. Now, what we would like to see is a straight line here. We'd like to see this to be curative therapy. It is curative in childhood leukemia. And what we need to do, I think, is find maybe the right time to give it, or the right way to give it, or the right combination to give it. But this is the drugs that are approved for lymphoma and leukemia. They cost about $300,000 to $500,000 for one dose. So if something's going to be that expensive, we want it to be curative. But on the other hand, it's giving hope to people that really didn't have any other options. And I think we'll find ways to manage the economics of this in a way that everyone benefits. And there are a lot of studies that are available using this, but it doesn't seem like there are enough studies, because we have patients that want to get on these studies, and it's very difficult. In order to make sure that it's safe, they limit how many spots there are, so they can treat 3 or 4 patients, make sure that they're all right, and then if they are, they increase the dose and we get another 3 patients. And so even though there are a lot of studies open, there aren't a lot of spots because we're concerned about the safety issues. But that is going to change because I think for some of these, the Bluebird in particular, we've determined the safe dose, and we're going to move into what's a phase 2 study, which are much larger studies. We're no longer trying to determine the safe dose. We're trying to determine how well does it work. This, I don't know if there's anything you really need to know about, but just to know that there are several different ones. I mean, I think this one will be opening up here in December, possibly January. I think this one is going to open up here next year, and the Bluebird will also be opening up here. So that this will be something that we'll be able to offer patients here in the coming year. Or you can go to China. It's remarkable how China is actually leading the way in this technology. Yeah, isn't that? Yeah, it's like the last thing you really would have. But I think they have maybe less regulatory hurdles, and they've got a strong, innovative and they've obviously got a lot of scientific expertise. And so some of the most rapid advances are occurring in China. And I do know of patients from the US that have gone to China to be treated with this. So there you go. What's that? Did it work? It did. The patient from San Francisco. Not my patient, another doctor's patient. And so the future of Carty in myeloma therapy, I think just like this technology was approved in leukemia and this technology was approved in lymphoma, it's going to be approved in myeloma. And I don't know when, but I think it might be possible next year, or maybe Raphael or someone else knows better. But I think it seems almost certain that this technology will be approved and will be available. And we need to find the safe way to give it. And a lot of the studies that I showed you, they all targeted the same molecule on the surface of the myeloma cell called BCMA. But there are new ones coming, and there are new ones coming along that target different things in the myeloma cell. And that's good because it may be that you stop expressing BCMA and you'll need something else. And so, and it's in some ways, it's very easy to modify this approach based on, as opposed to with drugs, because it's relatively simple to change what we call the vector, the way we engineer the cell. So we'll be able to keep modifying these things and keep modifying them in a rational, scientific way, which kind of means they're going to get better and better. And you'll notice here that the universal CAR T cell, that's what I was talking about before, that we'll get to the point where we have these immortalized cells that are growing indefinitely, and we can just take them off the shelf and give them to a person, and they'll eradicate their myeloma. That would be just amazing. I think that's it. Thank you.